Hello.
Good morning, madam.
Hello. Good morning.
Good morning, madam.
Start చేసిస్తావా?
Madam.
Okay, thank you.
Risk scoring in anesthesia. This is my topic. Good morning, all. Risk assessment is an important effort in effectively triaging patient in assessment in the clinic. Adequate evaluation improves patient satisfaction with anesthesia. Scoring systems helps in identifying high-risk patients and better risk prediction. Better counseling, informed consent, appropriate referrals to higher centers to compare among hospitals and units, and quality control. What's an ideal risk assessment scoring? The risk prediction system should consist of patient factors, procedure factors, care team factors. The patient's factors such as functional status, comorbidities, and immediate health status, and procedure factors like type of procedure, invasiveness, and urgency, and care team facilities like level of specifications, experience, and equipment should be considered. Coming to the basic scoring system, ASA physical status is a simple yet robust measure initially proposed by representative of ASA in 1941, not intended as a tool for predicting likelihood in perioperative morbidity and mortality, as it does not incorporate type of anesthesia or surgery. This is a newer ASA grading, in which we have 6 gradings. In the newer ones, the pediatric examples and obstetric examples are included. In ASA grade 1, normal healthy individuals are present. In A2, mild systemic diseases, 3 severe systemic
Hello,
diseases.
Srujan, slides change avatledu.
Oh, okay, man. Ma'am, change it, ma'am. Hello, ma'am.
Okay.
Ippudu cheppu. Okay.
In first severe systemic diseases, that is a constant threat to the life, are seen in 5 morbidly moribund patients were seen, and in 6 declared brain dead patients were seen. What is ASF physical status used for? For clinical communication between the anesthesia providers in sign-offs, assessment for staff and procedure location, and outcome predictors. For administrative purposes, for comparison between hospital performance. In business, for billing modifier, and research purposes, where we use as an inclusion criteria. The higher ASA physical status has been correlated with increased mortality and morbidity, unanticipated ICU admissions, longer hospital stays, procedure complications, and adverse cardiopulmonary outcomes. A study by Rips et al. Showed stronger correlation between ASA physical status and postoperative mortality, where we can see 4 and 5 having higher mortalities like 7, 11, and 50, and 1 to 3 having lower mortality rates like 0.2%, 1.14%, and 1.41%. Niha classification. It's a class, it has 4 gradings. In class 1, there's no limitation of physical activity with no symptoms and comfortable on lab test. In class 2, there is a slight limitation on physical activity, symptomatic and ordinary activities, comfortable at rest. In class 3, marked limitation on physical activities, symptomatic at less than ordinary physical activity. In grade 4, unable to perform any physical activity, discomfort with activity. The metabolic equivalence of the functional capacity, 1 month is usually equal to oxygen consumption by a 70 kg man of 40 years old, which is 3.5 ml per kg per minute. Less than 4 months is a severe functional disability, where simple activities like walking, racking of leaves, and eating, and ordinary activities were there, and more than 10 strenuous activities like swimming, skiing, running rapidly were present. These are between 4 to 10 also. Moderate activities like physical, say, playing tennis, climbing stairs of more than 2 flights, jumping rope were included. Cardiac risk assessment and non-cardiac surgeries. Usually, 30% of cardiac patients were usually present for non-cardiac surgeries. It's just like a tip of an iceberg, where the submerged portion is much larger, where we have a 9-fold increase in mortality, 30 to 4 increase in morbidity, poor cardiac outcome for 20 to 47%, poor long-term prognosis and cost escalation in 50%. These RCRS score, where we estimate the MACE. It includes ablation factors and procedural factors. The risk factors include the high-risk surgeries such as abdominal thoracotomies, peripheral vascular surgeries, ischemic heart disease and congestive heart failure, cerebrovascular diseases, insulin-dependent diabetes mellitus, and serum creatinine more than 2 milligrams per deciliter, which are patient factors. It predicts MACE like MI, pulmonary thromboembolism, VF, heart block, cardiac arrest. In MACE of class of grade 4 will have a major MACE of 11%, whereas 3 has only 6.6%, whereas class 2 and 1 has much lesser, which is 0.4% to 0.9%. It includes the number of factors involved. Like class 1 has 0 factors, class 2 has 1 factors, and class 4 has 3 or more factors. The limitations of RCRI poorly performs the predicting of postoperative mortality. Indices like diabetes mellitus offer minimal prognostic information. Renal insufficiency could be better determined by GFR. It may have included other indexes like age, peripheral artery disease, and functional capacities. RCI may underestimate risks of major vascular surgeries and do not include many types of low-risk surgeries. The preoperative levels of troponin and BNP are independent factors for postoperative cardiac risk complications. The Canadian Cardiovascular Society recommended measuring BNP levels in patients with RCR score more than 1 or any other risk factors, and they are recommended 2 to 3 days for once daily troponin value in BNP is elevated. NSQPI score. The American College of Surgeons has developed an online resource, which is an online risk calculator. The clinical data from over 1.2 to 1.4 million patients in the National Surgical Quality Improvement Program database were taken. The web-based tool incorporates 21 preoperative patient factors, which are such as ASA physical status, age, functional status, abnormal serum creatinine, and the current procedural terminology code for almost all specialties and subspecialty surgical procedures. It is not designed to provide perioperative recommendations, yet it is valuable in providing a common language for communication about the risk of the patient in the preoperative team. Guides more intensive interventions for prevention and most likely adverse outcomes, better predictive value than RCRI, and works well with the vascular group, whereas RCRI doesn't go well with the vascular group. The limitations include routine post-op troponin surveillance is not done, participating site underreporting. The Gupta is another perioperative score for major myocardial infarction and cardiac arrest. Patients who underwent surgery were identified from the ACS NSQPI database, and 5 predictors of MI and cardiac arrest were identified. They are type of surgery, dependent functional status, abnormal creatinine, ASA classes, and increasing age. This is a Goldmann multifactorial cardiac risk index. It's an older classification where we have perioperative third heart sound, myocardial infarction, more than 5 VPCs, age, emergencies, aortic stenosis, intra-arterial, intraperitoneal, and intrathoracic surgeries, and others for assessing, where we more than 26 points where have a higher risk of 22% of major cardiac events. This is a Dusky score, which is aimed at revealing cardiovascular risk in perioperative setting. It has some factors like pulmonary edema, Canadian Cardiovascular Society of Angina risk score included in it, which has a better predictor. The score of 22.6 to 100 points which is class 4, has 100% complications. This scoring where the Goldmann risk scoring and everything were taken, which indicates the positive predictive value of only Goldmann risk score has a more than 56%, less the other positive predictive values of other scorings were much lesser. So this indicates that the major cardiac events were not that much indicated. Only the presence of it only indicates the presence of obstructive CAD, not the plaque vulnerability during the intraoperative periods. This assessment of whether surgery can be taken up for the particular procedure for the particular group of risk patients, where the major risk patients will have with like unstable angina and unstable arrhythmias will have even the low risk surgeries to be considered for optimization and for evaluation, whereas minor risk patients can be taken for low risk surgeries and intermediate risk surgeries. There are some intraoperative scoring systems such as P-posium score and surgical APGAR score. The intraoperative and immediate postoperative characteristics are used in assessing postoperative outcomes. The best example is P-posium score, which is post-mort physiological and operative severity score for enumeration of mortality and morbidity score, and surgical APGAR score. The P-posium score incorporates 18 variables, including several intraoperative variables such as extent of surgery, total blood loss, and peritoneal solving into a complex mathematical equations for predicting morbidity and mortality. These limitations include complexity of the bedside applications, tendency to overestimate and underestimate mortality and morbidity in some surgical populations. Surgical APGAR score 10 points risk index based on 3 operative indexes such as tachycardia, hypertension, estimated blood loss. Facilitates early post-operative identification of the patients who warrant more ICU monitoring. The before scores which we didn't discuss were actually a pre-operative scores, and these are the intraoperative scores, which will indicate a better post-operative outcomes for an ICU admissions. Scoring for cardiac surgical patients. The most common used scoring system for CABG was developed by Parsons and colleagues. It's an additive model constructed and prospectively evaluated in 132 cardiac procedures, used as a benchmark for comparison among institutions. Numerous technical advances now in routine have diminished CABG mortality rates. This is the Parsons additive model, where we have female gender, morbid obesity, diabetes, hypertension, ejection fraction, age, reoperation, preoperative IABP, left ventricular aneurysms, emergency surgery, dialysis dependency, catastrophic states, rare complications and valve surgeries, and CABGs at the time of valve surgeries. This scoring system had a better outcomes for CABG. Society of Thoracic Surgeons and a STS National Adult Cardiac Surgery Database represents the most robust source of data for calculating risk adjusting scoring system. This is another scoring system for cardiac surgery patients. In 1989, the database included 829 participating hospitals in 2008 and has continued to grow. Models are updated every few years and are calibrated annually to provide an immediate and accurate tool for regional and national benchmarking, cardiac risk imagining, and cardiology consultation, and they have been proposed for public reporting. The calibration of the risk factors is based on the ratio between observed and expected results, and calibration factors are updated quarterly. The expected mortality is calibrated to obtain a national O/E ratio. Besides operative mortality, these models were developed for 8 additional endpoints such as reoperation, permanent stroke, renal failure, deep sternal wound infection, prolonged more than 24 hours ventilation, major morbidity, post-operative deaths, final short and long-term post-operative length of stays. This is the calculator which we usually use for STS scoring, where they have a single procedures like CABG or single valve procedures like AVR, MVR, or a combined procedures like AVR and CABG, MVR, CABG, where we have predicting the risk factors like risk of mortality, renal failure, permanent stroke, prolonged ventilation, and all. This is the factors included in STS scoring. This is and there are odds ratios where age has a odds ratio of 1.6 and female sex has a ratio of 1.4. The next scoring is the European score, a system of cardiac operative risk evaluation. Euroscore is the most famous scoring for cardiac surgery patients taken for cardiac surgery. The Euroscore was first developed in 1999 with risk factors such as patient-related factors such as age, sex, chronic pulmonary diseases, extracardiac arteriopathy, neurological dysfunctions, previous cardiac surgery, serum creatinine, active endocarditis, and critical operative states. And cardiac related factors like unstable angina, left ventricular dysfunction, pulmonary hypertension. The surgical risk factors such as emergency, isolated CABG, surgeon thoracic aorta, and post-infarct surgery. This indicates the mortalities for the risk, where 0 to 2 has a mortality of 0.8%, and 3 to 5 score has a mortality of 3%, and more than 6% has a score has a mortality of 11%. And the overall mortality is 4.7% in cardiac surgeries. In 2012, the Euro score was recalibrated as a Euro score 2, permits more accurate risk estimation, yet preserves the powerful discrimination of the original. It is recommended model for assessment of cardiac risk, surgical risk assessed from online and downloaded from smartphone application. This is an example of a Euro 2 score where it's calculated of a 60 years male diabetic for 15 years of chronic smaller recent anterior wall MI, had ejection fraction of 40 with mild MR, position for elective CABG. It came to a rough estimate of 3.34%. This is a Charles-Fouillé vascular score, which estimates the stroke complications in atrial fibrillation cases. It has risk factors such as heart failure, associated signs and symptoms of left ventricular systolic dysfunction, hypertension, age of more than 75 years, diabetes mellitus, previous stroke, transient ischemic attacks, vascular diseases, myocardial infarctions, age 65 to 74 years, and female sex. Coming to the respiratory system, despite the frequency with which postoperative pulmonary complications occur, as many as 5% of patients having non-thoracic surgeries, a consensus guidelines for perioperative evaluation and intraoperative management of the at-risk patient does not exist. As many as 1 in 4 deaths occurring within a week of surgery are pulmonary related, makes it the second most common morbidity after cardiovascular adverse events. These are risk factors which increase the pulmonary complications, such as patient risk factors like advanced age, ASA physical status 2, congestive heart failure, functional dependent, chronic obstructive pulmonary disease, weight loss, impaired sensorium, cigarette use, alcohol use, abnormal findings on chest examination. The potential procedure risk-related factors are aortic aneurysm, thoracic surgery, abdominal surgery, upper abdominal surgery, neurosurgery, head and neck surgeries, emergency surgeries. Actually, most of these surgeries were either high-risk surgeries or intermediate risk surgeries, and general anesthesia and perioperative transfusions. Potential laboratory test risk factors such as albumin concentrations less than 35 grams per dl, chest radiography abnormalities, and more than 7.5 millimoles per liter. This Rcri is an assessment of respiratory risk of surgical patient Catalona group. It estimates risk of composite endpoints of respiratory infections, respiratory failure, pleural effusion, atelectasis, pneumothorax, bronchospasm, and aspiration pneumonia. These score only estimates of the postoperative pulmonary risk, not about the mortality in cases. It includes factors such as age, perioperative oxygen saturations, respiratory infections, perioperative anemia, surgical incision location, duration of surgery, and emergency procedure. This Rcri score of high, more than 45%, indicates perioperative pulmonary complications of 42.1, whereas intermediate of 26 to 44 points has a 13.3% of pulmonary complications, and low risk, which is less than 26 points, has 1.6% of pulmonary complications. In lung resection surgeries, PFT is useful in predicting postoperative pulmonary complications by examining FEV1, predicting postoperative FEV1, DLCO, and postoperative DLCO by 3-leg stool model. This is a 3-leg stool model where the respiratory mechanics were evaluated by FEV1 and cardiopulmonary reserve by VO2 max and lung parenchymal function by DLCO. There are some bedside PFTs, such as examples such as Sabra's test or a breath holding test. More than 25 seconds is normal and less than 30 seconds has a severe cardiopulmonary reserve diminution. A Snyder's blow test, which estimates the maximum breathing capacity, where 6-inch is normal, where more than 100 liters per minute, and 3 inches with maximum breathing capacity has only approximately 40 liters, and 9 inches have more than, if we can blow a mastic of more than 9 inches, we have maximum breathing capacity of more than 150 liters per minute. The other tests were de novo visual flow test, which helps in identifying PEFR, peak expiratory flow rate, and watch and stethoscope test, breath counting test, chest expansion test, pneumotachography, right spirometry, and all. Coming to OSA, the stop bank questionnaire is a screening tool that has been validated for predicting moderate to severe undiagnosed OSA. Preoperative sleep evaluation and prescription of CPAP therapy is indicated in patients with stop bank scores of more than 5. The long-standing untreated OSA are at risk of developing heart failure and pulmonary hypertension and may benefit from echocardiac evaluation if the symptoms are present. This is the OSA scaling, where S stands for snoring, T for tiredness, O for obstructive symptoms, obstructive apnea, P for blood pressures, B for a BMI of more than 35 kg per meters, age, and neck circumference of more than 40, and gender of male. Coming to the renal diseases, the chronic renal disease has a risk factor of adverse cardiac events. The creatinine value greater than 2 milligrams per deciliter has a greater risk factors. The patient who have end-stage kidney disease have a significant risk of morbidity and mortality. One study examining 33,016 patients undergoing cardiac surgery demonstrated that those requiring preoperative hemodialysis had an increased 30-day morbidity and mortality equal to patients having urgent surgery, valvular surgery, and ejection fraction less than 30%. Patient at risk for preoperative AKI include those with pre-existing CKD or diabetes mellitus, especially in combination, and those undergoing procedures with administration of contrast media. Preoperative identification at the risk patient may change management, such as preoperative hydrations, changing the type of contrast media, maintaining high intraoperative blood pressures, which may be a bit of renal protective, and avoidance of hypovolemia. This is the rifle score, KIDCO score, all indicate the AKI in which the serum creatinine will raise more than 50% or more than 0.3 milligrams per deciliter within 48 hours. The rifle criteria increases the risk, injury, failure, loss, and end-stage renal disease, where the serum creatinine increases by more than 50%, or GFR decreases by 25%, serum creatinine increases by 100%, or GFR decreases by 50%. In failure, the serum creatinine increases by 200%, or GFR decreases by 75%. Coming to the hepatic diseases, the Child-Pugh score of class C cirrhosis have a mortality of extrahepatic surgery approaches 84%. Even the normal uninfilled procedures such as laparoscopic cholecystectomy has a higher mortalities. The mortality of patients with cirrhosis with elevated PT of more than 25 seconds over control is 83%, which is much higher, which is not even expected. In patients with decompensated liver cirrhosis, cardiac C status or MELS greater than 15, elective surgery should be postponed. These are the parameters used for in Child-Pugh score and the MELS score. In Child-Pugh score, albumin, bilirubin, INR, ascites, and encephalopathy were included. The Child-Pugh score has a score of 5 to 6%, which has a mortality risk of 11%, 11 to 22%, and B has 79% score, which has 44%, whereas C, which has a higher mortality risk of 83%. In MELS scoring, the serum contains parameters like serum bilirubin, INR, serum creatinine, where the score more than 15 is generally avoided for surgery. The other scoring of ADOPT LG scoring system, which is a Japanese researchers have established. The new scoring system with 2197 cirrhotic patients undergoing major surgeries to predict in-hospital mortality. It has factors such as patient's age, CTP's class, duration of anesthesia, and Charlson comorbidity index were used. This is the King's College scoring for transplantation, where transplantation is indicated for acetaminophen poisoning or non-acetaminophen poisoning. Where acetaminophen poisoning selection criteria includes arterial PSF less than 7.3 and prothrombin time of more than 100 seconds plus serum creatinine of more than 300 micromoles per liter with grade 3 and grade 4 encephalopathy. In non-acetaminophen poisoning, the perothrombin time will be more than 100 seconds, irrespective of grade of encephalopathy, or there can be a 3 of the following with non-A, non-B hepatitis, halogen hepatitis, or drug-induced toxicity, with age less than 10 years or more than 40 years, with jaundice to encephalopathy interval more than 7 days, with the prothrombin time more than 50 seconds, and serum bilirubin more than 300 micromoles per liter. Coming to the neurological diseases, affecting motor and respiratory functions such as myasthenia gravis, multiple sclerosis, Parkinson's disease, previous stroke, a cerebral palsy requires careful and intraoperative and postoperative management to minimize aspiration, respiratory complications, and exacerbations of the underlying conditions. In patients with previous stroke or transient ischemic attacks, medical management of AF and hypertension should be optimized preoperatively. Considering the delaying elective surgery at least until the peak of autoregulated disturbance has been passed, such as 1 month, is reasonable to decrease the risk. Mostly, the MACE remains elevated for 9 months after the ischemic stroke. Coming to the cancer patients, have a complications related to tumor mass effect, such as metabolism, metastasis, medications and therapies, metabolic abnormalities, and malnutrition. Difficult airway management is usually seen in cancer patients due to radiation and chemotherapy. The fibrosis occurs, causing a premature atherosclerosis of the carotid arteries, and hypothyroidism or other complications. Auscultation for bruise, thyroid function tests, and carotid Doppler studies should be needed. The causes for cardiac disease such as conduction abnormalities, cardiac myopathy, valvular abnormalities, and premature CAD, which may warrant an ECG and echocardiography, is done. As they undergo chemotherapy and radiotherapy, the conduction system may be damaged. The chemotherapy agents are associated with cardiac, pulmonary, hepatic, and renal toxicities. We should be aware of the gliomas in therapy, in which in the prior 1 to 2 months is particularly important to identify avoidance of hyperoxia, where FiO2 may more than 30% preoperatively is critical in avoiding ARDS in these patients. It's a Kaplan risk model for venous thromboembolism. These factors have 1 point of each, and these points have 5 points of each, which are stroke, electric arthropathy, arthroplasty, hip and pelvic and lung fractures, and acute spinal syndromes. And these are 3 points and 2 points. These factors usually help in identifying the thromboembolism post-surgery and perioperatively. Diabetes mellitus. The preoperative assessment will focus on end organ dysfunction and glycemic control. The cardiovascular, renal, and neurological system should be evaluated. Usually they have the HbA1c estimation helps in perioperative evaluation of the glycemic control. Though this is not a risk assessment score, this is the criteria for discharge. These are modified altitude score and BAT score. The modified altitude score has a score factors such as respirations, O2 saturations, consciousness, circulation, and anxiety. The PAT score of the post-anesthesia discharge score has a vital signs, activity, nausea, pain, surgical bleeding. The PAT score is used for discharging the patient from the wards, and the altitude score is using for shifting the patient from the PSU to the step-down PSU. Before ending, there are other scores which I haven't included due to my laptop issues, such as scoring for difficult intubations, like Lemon scoring, Malpathy scoring, and Wilson scoring, which helps in difficult intubations. And in patients which are kept in ICUs, there were few scoring for estimation of sedation, such as Ramsden scoring and Lisman scoring. These were the references from which we have taken the PPTs. Thank you. Hello, sir. Madam.
Hello, Sujan.
Madam.
Sujan, morning.
Good morning.
చాలానే స్కోరింగ్ సిస్టమ్స్ చాలానే చెప్పావు, బట్ యా అంటే కొంచెం మధ్యలో స్పేస్ ఇచ్చి కొంచెం ఎక్స్ప్లెయిన్ చేసి చెప్తే ఇంకా కొంచెం ఎక్కువ బుర్రలోకి ఎక్కేదేమో. అండ్ ఫాస్ట్ గా చెప్పి చాలా స్కోర్స్ చెప్పావు. సో ఐ డోంట్ నో హౌ మచ్ ఎంటర్డ్ ఎనీబడీస్ బ్రెయిన్. బట్ కొంచెం పీపీటీ బట్ షేర్ చేస్తావా?
Yes, ma'am.
సో దేర్ ఆర్ సో మెనీ థింగ్స్ అండ్ కామన్లీ యూస్ థింగ్స్ ఏంటి ఇందులో చెప్పు. కార్డియక్ రిస్క్ అసెస్మెంట్ లో nowadays we are not using Goldmann risk
Ma'am.
index కదా.
We are using RCI, Lee's RCI scoring, madam.
ఏది?
Lee's RCI scoring, madam.
ఓ యా, అది ఒకటి. అదే అంటే లాస్ట్ లో ఒకటి కామన్లీ యూజింగ్ స్కోర్స్ అని జస్ట్ నేమ్స్ పెడితే బాగుండేది, ఎక్కువ యూజ్ చేసేవి అనుకున్నాను. యా, అండ్ ASS స్కోరింగ్, చైల్డ్ పఫ్స్, మెల్స్, యా ఇవన్నీ చెప్. యా, గుడ్. బట్ సమ్ ఆఫ్ ద స్కోరింగ్స్ which not many people use and we also don't use. Unnai kanni scores use cheyyam kada. There are a lot of scores. PPT share cheyi.
Okay.
Thank you. Yeah,
Thank you.
thanks.
Hello.
Sir.
Hello.
Sir.
Good morning.
Good morning, sir.
What test you will do when you want to shift a patient from post-operative recovery room after giving spinal anesthesia?
Sir, we will check for the level of the anesthesia, sir. Mostly we will check for the PROMAS scoring.
Okay.
Is there any regression of the level?
Yes.
We'll just ask for the patient using the
Two-segment regression test. That is good. You have not given this Glasgow coma scoring.
Yes, sir.
Thank you, Srujan.
Thank you.
Sir, madam, actually this is our fault because 2 days time ఇచ్చాను సృజన్ కి ఎమర్జెన్సీగా. బికాజ్ ఇంకొకరు ప్రిపేర్ చేయాలి, వాళ్ళకి అవ్వదు అంటే సృజన్ కి ఇచ్చా. నెక్స్ట్ నైట్ ల్యాప్టాప్ నాట్ వర్కింగ్, సో అందుకే ఎంత అయిందో అంత సో చేశారు. నెక్స్ట్ కొన్ని యాడ్ చేయడానికి కూడా ల్యాప్టాప్ వల్ల ప్రాబ్లం అయింది.
I have one more question.
అయినా చాలానే చేశాడు.
చేయడానికి అవ్వలేదు. సో ఆల్మోస్ట్
అసెస్మెంట్ లో ఒకటి మిస్ అయినట్టుంది. ఈవెన్ ఏవిపియు చూస్తాము, ఇది చూస్తాము. ఇంకొక న్యూరలాజికల్ అసెస్మెంట్ ఇంకొకటి ఉంది, క్లాసిఫికేషన్ GCS కాకుండా అదొకటి. ఇలాంటి కొన్ని కామన్ గా యూజ్ చేసి కొన్ని మిస్ అయినాయి. బట్ చాలానే చేశాడు ఇన్ స్పైట్ ఆఫ్ షార్ట్ టైం.
షార్ట్ టైం అంటే యాక్చువల్ గా నైట్ ల్యాప్టాప్ ఇస్ నాట్ వర్కింగ్, సో దట్స్ వై అన్ఏబుల్ టు prepare the PPT extra things. I mean, you told about everything, no? So he's not able to done. So that is the issue.
It's okay. Good. Thank you.
Okay, Srujan, కొంచెం మేడం సార్ చెప్పినవి ఆ 2-3 స్లైడ్స్ కూడా యాడ్ చేసి కొన్ని డిలీట్ చేసి అప్పుడు గ్రూప్ లో పెట్టేసి అది బెటర్. ఏ మేడం?
Fine, that's fine. Okay.
Okay. Thank you. Thank you to all.
Thank you.
Thank you, Srujan.
Thank you.